Okay, so now they're filtering in. All right, I do have 3 o'clock Central, 4 o'clock Eastern time, and let's get started. Good afternoon. Thank you all for joining. I'm Nizar Jarjour, and it's my privilege to introduce today's special session on billing and coding, particularly as it relates to our advanced practice provider colleagues. Before we get started, I just want to remind everybody we are preparing a very nice in-person meeting for the division heads at the ATS on Saturday, the 16th. So please do your best to join the in-person meeting. We have a number of topics that we're going to be discussing, including coaching and how to recruit and retain faculty, and introducing a new topic of basically the attention we need to pay to our senior faculty as they transition from full-time work to other alternatives such as part-time or retirement. Without further ado, I want to ask Sai Parasarthi, my colleague on the executive committee, who really has championed the work on education regarding billing and worked with Scott to develop this series. So Sai, thank you so very much for your effort on this. I'm really grateful to you, and the floor is yours to introduce our topic and speaker.
Yes, thanks, Nizar. And yes, I'm learning a lot by having Scott come give talks to us. So it's in many ways very beneficial to me and my division as well. Scott doesn't need introduction, but I'm going to be formal and introduce him. Dr. Manaker is an actively practicing pulmonary critical care physician in the pulmonary critical care division at the Penn in Philadelphia, where he's also a professor of medicine and physician advisor to Penn Medicine Office of Billing Compliance. He's given many talks and represented both the American College of Chest Physicians as well as the American College of Physicians, ACP, at the AMA, American Medical Association's RVU Update Committee, or RUC as it's called, in the past. And he currently chairs the RUC Practice Expense Subcommittee for AMA. He serves on the Novita Solution Medicare Contractor Advisory Committee for Pennsylvania, and was appointed to the 4th term in the Center for Medicare and Medicaid Services Hospital Outpatient Panel on Ambulatory Payment Classification Groups, Federal Advisory Committee. He gives lectures widely across the U.S. as a physician advocate, speaking on chart documentation, coding, billing, reimbursement topics, including teaching physicians regulation, critical care, E&M coding, consultation policies, non-physician providers, which he's going to touch upon with the emphasis today, and an impact of the EMR and AI and all the wonderful things that are in the pipeline. So we are absolutely delighted to have Scott amongst us, and take it away, Scott.
Thank you. Thank you very much, Sai and Nizar and Lauren, and for the invitation and the warm introductions. And thanks to all of you for being interested enough to spend an hour with us today. So I'm going to start sharing my screen. Let's see. Here we go. And put this into full screen mode. All right. And we'll go ahead and get started. Usual ground rules apply. So please make sure your microphones are muted, but please unmute them. Anytime you want to ask any question, have me slow down, repeat something, embellish, clarify, whatever. If for some reason you are shy, bashful, or intimidated, and I find it hard to believe that anyone affiliated with the Association of Pulmonary Chiefs is going to be shy, bashful, or intimidated. But if you are, and you type your question in the chat, Lauren will happily interrupt me on your behalf. I'm not going to spend much time going over the way too many committees, largely dealing with physician reimbursement, sometimes dealing with hospital and health system reimbursement. And we'll touch upon that on the first couple of slides. Here's the usual disclaimers. I have everything I've done for the past decade or more here, just so no one can say I didn't tell you. And so that brings us to the topics. I was asked to do a little potpourri of smattering of different topics and focus on critical care with respect to advanced practitioners. I thought that would take the lion's share of the talk. So I was going to cover the two shorter, smaller topics first. The first being non-face-to-face consultations with patients, and the second being the G2211 longitudinal care add-on, because that winds up being a great opportunity for pulmonary divisions. Even for an individual physician, it is an opportunity. And we'll talk about that in more detail in a couple of slides. But first, non-face-to-face consultations. People talk about this a lot. These CPT codes have been around since, and in effect in the physician fee schedule since 2019, January 1, 2019. So why do we all talk about it, and why do so few of us do it? Because operationally, it's really hard. It's a heavy lift. And financially, economically, it's not worth it. So let's dive into the details here summarized on this slide. There are 4 time-based codes for a non-face-to-face visit where a primary care physician or another specialist can request you to basically do an electronic chart biopsy. Not see the patient, not talk to the patient, just look through the chart, look through the available records, images, etc., and then provide your recommendations, provide your report. And these 4 time-based codes are listed here, along with the minutes. So if you spend less than 5 minutes, you can't looking through the chart, you can't bill it at all. And then you would bill the corresponding CPT code, depending on how much time it took you to look through the chart, and then write up your report and send that either handwritten or electronically typing to the requesting provider. And in addition, you have to call them. There's some caveats here. The first is, since this is just like every other evaluation and management service, if the patient is in the Medicare fee-for-service program, they are going to have a copay. And therefore, they must consent to this service. So the physician or advanced practitioner, the person requesting your consultation, has to document in the chart that they informed the patient and obtained the patient's consent to have you look through the chart and do the chart biopsy and get back to them. Then you need to document in your record how much time you spent providing this service, and then you need to send your report back, both verbally and in writing or electronically, to the requesting provider. And a couple more caveats. There's no face-to-face encounter allowed for plus or minus 14 days. So you can't do this if you or someone in your provider group has seen the person in the preceding 2 weeks, or plan to see the person in the following subsequent 2 weeks. And if you are like most of us and you're booked out 3 months in advance, that includes you can't see the person with your next available appointment. So if your next available appointment is in 2.5 months, and you say, I really got to see you in the office, you can't give them that appointment in 2.5 months because it's your next available. Similarly, if you're going to be assuming the care of the problem, so you're consulted for COPD or interstitial lung disease or hypoxemia or whatever, and you say, I'm going to take over managing this problem, you can't bill this service at all. And then lastly, it's not reimbursed by all payers. Many managed care companies and commercial payers will not cover these services. So at the bottom of the slide, it says establishing the workflows is key. And that's because if you're going to be providing this service, you really need to spend a lot of time with whoever has your electronic health record, setting up a process and including your financial people, because you don't want to be setting this thing up and then it turns out 70% of your payer mix doesn't even cover it and you're doing it for free. You need to have a process that ensures the requester, when they are electronically requesting you provide this service, they have to attest that they have documented in the record that they have obtained the patient's consent, because the patient's going to get a bill. So there's a lot of build in order to make this work. And I actually do not know of any pulmonary practices that are doing this or the next pair of codes we're going to talk about, which are an ever so slightly easier lift, because there's only one CPT code for us as the consultant, and only the written report is required. So if you get that legitimate request where the requestor has obtained the patient's consent, you do the chart biopsy, you type out your report in the electronic health record, and then you send it back to the requester, you're done. But everything else that I described about you can't assume the care of that problem for the patient, you can't have seen, and no one in your group can have seen the patient for 2 weeks before or 2 weeks after. And you have to figure out if your payers are even going to cover this. Because if Medicare fee-for-service, as in most of our practices, is somewhere in the range of 15 to 25% of your payer mix, that may be the only payer in your market who actually covers these codes. Now, the one nuance for this pair of codes that becomes really important, the first code is for the consultant. The second code is for us the first code is for the consultant. The second one is for the requester. You'll notice they both have the same number of work RVUs, 0.7. And I've talked a little bit about establishing the workflows. Most of us don't want to provide these services, because whether you're looking at the RVUs on the prior slide, and I forgot to mention, Lauren's got a PDF of the slides for people who are interested, and she'll be shooting around a link to the recording of this. You don't need to furiously scribble, snag screenshots, or worry about copying information down. Most of us would not want to provide this service, because if you spend the minimum of 30 minutes in order to generate and send back that written report, in that same 30 minutes, you could see a level 4 subsequent office visit, or do that office visit by telehealth and generate 4 or 5 times the number of RVUs. So it winds up being very inefficient economically and financially, as well as a heavy lift operationally. The only practices that I'm aware of who do this on a regular basis, particularly if you look at the claims data for these codes, many psychiatrists, where they will use this to obtain a quick answer to a medical question to consultants in their marketplace who are willing to answer the question, usually about pharmacologic management of various psychiatric diseases, side effects, and toxicities and the like. And secondly, overwhelmed medical specialty practices like infectious disease, rheumatology, and endocrinology, where they would rather have someone do these kinds of consults to largely answer quick questions and prevent medically unnecessary consultations, so that their in-person and telehealth clinics can be full of more likely, legitimate, appropriate patients. Another aspect of the heavy lift is your process needs to make sure that if you do want to provide this service, you're providing the service for clinically appropriate patients for whom a chart biopsy is sufficient. You probably don't want to be providing these services for shortness of breath or new hypoxemia for people who are going to need extensive workups and need to be seen. These are for one and dones. So you can have a list as the requester is filling out your process sheet leading to submission of the consult. You can have a bunch of diagnoses listed. If this is why you're sending the patient, please don't we're going to offer you up an in-person or telehealth consultation for your new patient. I'm going to stop there to just quickly see if there's any questions before we move on to establishing reimbursement for longitudinal care of the patient.
Very, very quick question, Scott. What about things like lung nodules? Do they fit into this? Because it seems like there's always a protocol and easy, and when they get the report from the radiology, they're all worried, and sometimes it's very quick and easy for response. What do you think?
So once again, I think that's a perfect example of where you could have a well-trained advanced practitioner who works with your IP group doing this to unclog your nodule clinic. And in the context of this, they can reassure the patient, say the nodules are benign. The problem is they don't want to then be assuming care of the nodule, reassuring the patient looks benign and we're going to get another CT in 3 months, because now that's in essence transferring the care of this problem to your group. So you need, again, good example of where it might be, but when you start thinking through the details, doesn't work out so well in our particular specialty. Good question, though. Other thoughts or questions? All right, so let's move on to G2211. So this is the add-on code. It's not a modifier. It's just like a CPT code, and you add it on to an office visit. This has been around now for several years, and this was CMS' original intent to drive this for primary care physicians who do a lot of things that there aren't CPT codes for, including building longitudinal relationships. Now, we as medical consultants and our surgical brethren as surgical consultants also build longitudinal relationships with patients. And I personally like to use the example of patients with peripheral vascular disease and diabetes who see the vascular surgeon more frequently than they see their primary care doctor for management of their chronic non-healing wounds. This service is a focal point for all services, think of primary care, or ongoing care of a patient's serious or chronic condition. It's not a serious and chronic, it's a serious or a chronic. So Nizar, your example of lung nodules is a perfect example. And we're going to talk about a bunch of pulmonary examples in a slide or two. This is a 0.33 work RVU add-on. And if you think about all the patients that you're bringing back for follow-up visits, the overwhelming vast majority of them are all eligible. So if you're not reporting G2211, you're leaving 0.33 RVUs on the table with every follow-up office visit. And your new visits if you're scheduling the patient to come back at that time. But it only gets added on to an office visit, but it can be used for telehealth visits. Now, this is my general slide that I use in primary care and all the other medical specialties when talking about this. You can use it for any condition. In 2025, Medicare fixed the problems with vaccinations. So now, to the extent that we are administering the vaccinations we know and love, Pneumovax and influenza and RSV, providing that vaccination will not prevent use of the G2211. But what will prevent using G2211 is performing a procedure or a diagnostic test on the same day that requires a 25 modifier. And that's because part of the rationale and part of how CMS made this budget neutral is they said, this is for all the things that you can't bill us for, but you actually do to take good care of the patient. But if you're also performing a diagnostic test or procedure on this day and putting a 25 modifier on your office visit, each test, each procedure has a little bit of work added in and payment added in for the work that you did before the test of procedure and the work that you do before or after the procedure. So we're not going to pay you twice for that additional work, with full payment for a procedure or a test and also a G2211 for your office visit. So that's why you can't do PFTs, as an example, on the same day if you're going to slap a G2211. And I'm going to show you some data in a slide or two. I do want to talk about the fellows, because the fellows, when they are working in the practice, are functioning as members of your group. And so the attendings who are supervising the fellows in their practice, they can add the G2211. Now, if you've got a general pulmonary fellows clinic, the way we have a general medicine clinic, and it's team-based care, the patient comes in 3 times this year. They're seen by 3 different fellows. Each time the different fellow is supervised by 3 different attendings. All 3 of those visits have the G2211 slapped on, because the longitudinal relationship is with the provider group. Similarly, somebody who's covering your patient for you and sees them in the office, they can add the G2211, even though you're not their primary pulmonologist, because you are all members of the same provider billing group. You're going to see when I show you the data that this is a huge opportunity for us in pulmonary. Our cardiology division built this reminder prompt, and it is there. It pops up every time a cardiologist schedules a follow-up office visit for the patient. And on the one hand, about 35% of them found it annoying, and on the other hand, about 2/3 of them found it useful, so they decided to not shut it off. But general medicine has built a prompt like this, but not many other specialties have, and I don't know any pulmonary groups that has. Now, as I've been alluding to, pretty much every patient that you're scheduling a follow-up visit for should be having this slapped on. It'll be stripped off if they get PFTs, as you'll see in a moment. But everyone that you're just having a routine office visit and renewing their meds for their asthma or their COPD, you're seeing them for ILD, they're having a serial evaluation with a couple of diagnostic visits for whether they should have bronchoscopic valves inserted or go for a transplant, or it's nodule clinic and you're just following their nodules. Every patient that you follow with lung cancer or who has had their lung cancer surgically resected, radiated, gotten chemotherapy, every patient with bronchiectasis, they all have a longitudinal relationship with you as their pulmonologist. When they're having a bronchiectasis flare or a question about their nodule, they're not calling their primary care doctor, they're calling you. So just think about all of those chronic diseases. Now, this is the data from the first couple of months of 2024 in our department, comparing all the specialties as we were trying to ramp up the adoption so that we don't leave money in RVUs on the table. And what you can see is pulmonary is pretty regularly and steadily in the 15 to 25% range of follow-up office visits, whereas cardiology is closer to 2/3. And this stunned me until we started trying to understand, why is this happening? And I never realized how many of my colleagues in our division get one or another pulmonary function test on virtually every office visit, whether it's an oxygen qualifying walk, whether it's spirometry or full PFTs, whether it's a 6-minute walk test. And so that volume of PFTs winds up stripping the G2211 off from at least our pulmonary practice. In the cardiology practice, in contrast, if you think about it, all the echoes and stress tests, the Holters, those are all done prior to a cardiology follow-up visit so that the cardiologist has those results. And so they're not having as many 25 modifiers added and the G2211 stripped off.
Scott,
Yes.
so I just was wondering if you can share. I mean, these are the rates with which it's being billed, or the rates with which it's being reimbursed in terms of collection.
Okay.
If you
I
can
can
shed
share
light.
that data. I can share that data with you. So these numbers are the rates for which the G2211 was being slapped on for the office visits. Now, in terms of payment, you are absolutely correct. A small number of payers do not reimburse for the G2211. So, as with the non face to face consultative services, you do need to work with your finance people and figure out what the deal is based on your contracts. Now, I can tell you in our marketplace, the overwhelming vast majority of payers, and we have over 100 payers, cover this. Financially, what I can tell you is one of our largest managed care payers does not. And so they're obligated to cover services that are covered by Medicare. And so we are in the midst of a contract dispute, and there are enough dollars, like in the millions range, that there's potentially going to be a lawsuit demanding that in accord with the contract, they have to cover this service. We do have custom software built in Epic, our electronic health record, that looks at the payer. So providers do not do the wallet biopsy. We just provide one standard of care, and that standard is excellence for everyone, regardless of who their payer is. When the charges go into the billing router, it then does the wallet biopsy. And if it is a payer that does not pay this service, then it gets blocked so the patient doesn't get a subsequent bill for the full charges as a non-covered service. If, on the other hand, your payers don't pay this, considering it as bundled into the office visit, then there would be no opportunity under most contracts to pass those charges on to the patients.
Great. I think Dr. Sinner had a question. I saw his hand go up and then go down, so I want to make sure he's able to get it.
Oh, thank you. Yeah, because when I'm sharing my slides, I can't see the chat.
Right. Thank you. Hi, Scott. So it was actually at the beginning of the PFT discussion. We went through this whole similar discussion. My question is, there was this issue that arose in our compliance folks, which they said if the PFT was interpreted on a different day, even if the actual test was done on the day of the visit, that would be okay, and you could do 2211. I don't know if you've heard any discussions around that. It seems a little too clever, but I'm just wondering.
Yeah. When the claim goes in for a diagnostic test, it usually has the date of the service and the date of the interpretation.
Yeah.
And so we have a more conservative interpretation, and we strip the G2211 off, even if the test is read days later, and that payer allows reporting the test on the day that it was interpreted rather than the day it was billed. Most payers want the date of the interpretation, the date of the claim to match the date that the test was performed, not the day that it was interpreted.
Okay. And then a second question from that is, what if you had another individual interpreting the PFTs?
Well, remember, you're not individuals. You are a multi-headed hydra, right? You're a multi-headed organism.
It wouldn't help.
It goes by goes by the provider group. Yeah.
And what if it was somebody? Do you have? This is, I guess, more esoteric, but there are some ways to not have everybody be a member of the same group. Like if you have a sleep group, like you sometimes have it's a little philosophical, but we sometimes break things out that way.
You can see from this slide, we have a separate sleep division, and they are in fact separate, but they don't do pulmonary. And
Right.
so it's the same in cardiology, where you've got clinical cardiology, interventional, EP, and
Yep.
now heart failure, heart transplant. They're all separate groups, and so they can't. There are limits. They can't cover each other's patients. There's only a certain number of days and additional modifiers that you can make cross coverage arrangements and so forth. There's a lot of operational barriers to doing that.
Okay. I think particularly with pulmonary critical care, you have people who are mostly one or mostly other. We still have people who do sleep critical care and pulmonary.
Yeah.
And so we generally assign them to sleep because that's where most of their footprint is. But, it sounds like there's some rules about whether you can really do that. And you'd have to look at their overall footprint and some other things.
Yes.
Okay.
Yes.
All right. Thank you.
Sure.
Scott, I have a question. You mentioned that 2211 could be used in nodule patients potentially.
Yeah.
For example, in my practice, I see patients every 30 minutes, regardless they are return or new.
Okay.
And some of them are nodule patients, but I don't spend extra time with these patients. I do have longitudinal continuous care with them. So does the time require in order to build 2211?
There's no time requirement for it. So the 30-minute threshold for a level 4 visit, the 40-minute threshold for calendar time on the day is whether or not you're going to add a G2211. And the nodule actually is one of the nodule patient is one of the clinical examples I use. So you see a patient for the first time because they have a new nodule. Oh, you got a nodule. We're going to follow this with a CT scan in 3, 4, 6 months. Any questions, problems, you're going to call me about this nodule. So on my 99204, 99205 new office visit, I add the G2211. And then they come in and I get CTs over the next 2 years and the nodule's stable. And I say, okay, after 2 years, it's stable. You're done. You don't need to come back and see me anymore. There's a G2211 on that new visit and every one of the subsequent office visits except that last visit. Because I'm ending the longitudinal relationship. It's goodbye, good luck, God bless. Call me if you need me in the future. I've ended the longitudinal relationship. So there's no G2211 on that last office visit.
I see. So when you quote unquote graduate the patients to their primary because you are done 2 years, or you convert yourself if you want to keep them in your clinic as a lung cancer screening after 2 year follow-up module, then you cannot do 2211 anymore after that point.
Yes, and that's a perfect nuance that is worth emphasizing. If you convert them to a once-a-year lung cancer screening CT and you're managing that, then they remain a longitudinal patient in the practice. If, on the other hand, you're done, go back to your primary care, they'll get your low-dose CT along with your colonoscopy every decade, then you're done.
Okay, got it. Thank you.
Other questions? Okay, a couple more things about the G2211. This came out electronically about a month, 6 weeks ago, and it was just in last week's JAMA, a research article looking at the Medicare fee-for-service billing of G2211 in the first year, calendar 2024. And the blue portions on the left of the bar graph are the total eligible visits that the G2211 was billed compared to the yellow, the eligible visits. And you can see there's a huge opportunity. And you can also see that huge opportunity is non-denominational. It's as equal there for primary care as it is for medical and surgical specialists. So pulmonary, with the red arrow, you can see the primary diagnosis for the visits billed with the G2211, sleep apnea. So it would seem that for the subset of us who are accurately reporting this, it would seem to be people who do a lot of sleep rather than all of the other diagnoses that we've been talking about. A couple things to help you increase adoption of this. You can build a speed button as a default, as we have done, or you can use the wrench in the upper right-hand corner. These slides are all from Epic. If you're using different electronic health record, of course, it's going to be different, but the majority of academic practices, of course, are on Epic in this era. You can use the wrench in the upper right-hand corner and add it as a speed button, customized if your health system hasn't built this. And we've talked about using this widespread in pulmonary. Another issue that comes up is, what if you're seeing the patient for an acute illness? Now remember, whether or not you're going to survive somebody looking at your charts in an audit is going to depend on what's written, not what you did and not what you remember and not what your usual practice and pattern is, what's written. And so if your ILD patient comes in and says, I got a cold and I couldn't get in to see my advanced practitioner, I didn't want to go to urgent care, and their chest is clear, their vitals are stable, you diagnose viral bronchitis, you don't give them antibiotics, you tell them, just go use over-the-counter cold meds. What you see in the blue box is the entire note. So if you're writing more than that, just think about all the copy and paste crap that's polluting the notes, creating chart bloat, right? Note bloat. That's the entire note. And that fulfills the criteria for a level 3 visit. But the documentation here is key. And that's clear from these discussions with CMS officials. It's what's in the documentation. And so you can take that note and simply add that they can continue those over-the-counter cold meds since it doesn't impact their CellCept dosing for their ILD. Now you've converted this low complexity visit to a standard moderate complexity visit on the right, where you get a level 4 instead of level 3, and you can add the G2211 because in the context of this acute illness, you are in fact factoring into your thinking their longitudinal interstitial lung disease and managing their ILD meds. I want to make another point here. If you actually pull the article and read it, I don't agree with the authors. They've got the billing data here, and they say that CMS failed to adequately direct this to primary care, which was their intent, because it seems that in aggregate, more than half, and it's just over half, is being done by medical and surgical specialists. Well, the thing is, it's done by billing group and specialty, and nurse practitioners and physician's assistants are a completely separate enrollment specialty. And if you take a look, the two most common diagnoses are hypertension for both of those. So my guess is that if you actually analyze this at the level of the billing group rather than the enrollment specialty, and add in to family medicine and internal medicine all of the NPs and the PAs and geriatrics down there third from the bottom as yet another primary care specialty, that it would in fact flip to more than 50% going to primary care practices. But regardless, there is a big opportunity for physicians of all specialties to take advantage of this. So that's a great transition to the last topic, which is working with advanced practitioners in the ICUs. Remember that since the Balanced Budget Act of 1997, not just NPs and PAs, but clin nurse specs, social workers, midwives, CRNAs, and clinical psychologists can all bill. Until several years ago, when they revised the split share regulations, we could all manage supervising advanced practitioners very similar to how we manage working with interns, residents, and fellows, even though it's completely separate regulations for the teaching physicians compared to advanced practitioners. We could operationally and functionally manage them the same. We can't do that anymore since the split shared regulations changed back in 2022. And now the person who gets the bill is the one who does the substantive portion of the visit, in contrast to the teaching physician regs. Now, the advanced practitioners, there's actually 3 separate sets of regulations. The first regard them functioning as independent providers. The second functioning incident 2, which is only in the physician office setting. And at academic medical centers, virtually all of the medical and surgical specialty practices are not physician offices. They are hospital-based ambulatory outpatient clinics. And so they are considered a facility setting, not a physician office, even though we all talk about seeing patients in the office. It's a facility setting, and so the split shared regulations are the ones that apply in that setting. And so in the majority of our outpatient office practices, the advanced practitioners can either function independently or we can supervise them under the split shared regulations. If they are functioning independently or under split shared, there can't be a double bill, and so they can't be carried on the hospital's cost report. If the hospitals are paying their salaries, there needs to be financial arrangements so those costs are borne by the practice. There are a variety of ways to make that happen. The practice can simply hire the advanced practitioners. The practice can lease the advanced practitioners, or there can be a revenue stream that is modified and offset by the advanced practitioners' revenues. So, for example, let's say your interstitial lung disease program gets hospital support, and to the tune of $1 million. Well, that $1 million can be offset by the revenue that the advanced practitioners are generating, so that it's only $962,000 or $800,000 or something like that. So there's a variety of financial circumstances. I want to highlight that in 1998, that first year after the Balanced Budget Act when it was in effect, there was no billing by advanced practitioners as for critical care services, or trivially small. But by 2023, which is the year for which we have the most recent available Medicare fee-for-service data, you can see that in aggregate, the advanced practitioners have literally caught up and potentially surpassed emergency room physicians with that yellow wedge. So they are now providing almost a quarter of all the critical care hours to the Medicare fee-for-service program. So a couple do's and don'ts. If you are working with the advanced practitioners for critical care time, and I've got a lot of slides, we're also going to talk about hospital visits, because remember, not every patient in an ICU is going to be critically ill and for whom we can be billing critical care. So we need to just quickly review some of the hospital billing requirements as well. You can pool the non-overlapping time for evaluation and management services because you can get credit for the substantive portion. And I'll show you some examples of that in a tabular slide coming up. But remember, this is only for the critical care time and the critical care hours, none of the ICU procedures. And you can't do split shared billing with medical students or residents because those are subject to the teaching physician regulations. As I mentioned in the last slide, the advanced practitioner doesn't need to be directly employed by the practice group, but they have to be linked to your provider group. And remember, many advanced practitioners, particularly critical care advanced practitioners, may be linked to multiple provider groups. We've got some advanced practitioners. They'll work in some of the medical ICUs. They will also work in the CT SICU as well. with the anesthesia critical care people. So they're going to be linked to both types of provider groups because their enrollment specialty is as a nurse practitioner or as a physician assistant, not as a pulmonary physician or intensivist or anesthesiologist. Now at Penn, we've got a nuance. A couple of years ago, they changed the regs for a split shared service, you had to physically see the patient. At Penn, we still say that you have to actually see the patient, largely because we weren't sure that the physicians would ever be seeing the patients, and we didn't want some physician sitting in mission control signing off on lots and lots of patients from lots and lots of advanced practitioners that they really had no longitudinal relationship with and never saw. Now, for critical care, remember it's time-based, and you report that first critical care hour for as few as the first 30 or as many as the first 74 minutes. And now, due to a CMS error, you actually report only that first hour for the first 104 minutes. You got to get to 105 minutes before you can actually bill that subsequent half hour. And remember, the substantive portion is going to remain based on time. So you might see the patient for the first 40 minutes of the day, and then they crash later in the day, and the advanced practitioner comes running and spends 50 minutes, totaling 90. Now all 90 of those minutes gets billed out in the name of the advanced practitioner. And as was on a prior slide, I forgot to mention, the Medicare fee-for-service program pays 85% of the Medicare physician fee schedule for advanced practitioners. What the advanced practitioners will get from your other payers, including Medicare Advantage plans, is totally dependent on your contract and to the extent to which they will issue a provider number to that advanced practitioner. So you may have one payer who won't issue provider numbers to advanced practitioners in medical or surgical specialty practices. We bill those out at 100% of our fee schedule to that payer in the name of their primary supervising physician. Another payer may pay 85% of the Medicare physician fee schedule. Another payer may pay 85% of their standard physician fee schedule, which might be 120% of Medicare fee-for-service. Another payer may pay 85% of your contracted physician rate, which might be 200% of Medicare for the physicians, so that you'd be getting 170% of Medicare for those advanced practitioners. So need to just think through and understand the range of how your contracts work in your particular market. And so let's not get confused when we're sequentially working with an advanced practitioner. If the advanced practitioner sees the patient first and spends the amount of time in the first column, and then the patient crashes, and you come running later in the day with the time in the second column, until you get to that 105th minute, you are not able to report that subsequent half hour. And since the advanced practitioner would have performed the lion's share of the time in this example, that first hour gets billed in the name of the advanced practitioner. In this example, if the physician sees the patient first and the advanced practitioner goes afterward, well, then the billing goes in the name of the physician who's done the lion's share of the substantive service. I want to show you an example here. This is actually from our cardiologists, because when we're working with advanced practitioners, we have the advanced practitioners providing the care, but the attending writes the note and the services so that the bills all go out in the name of the attendings. In contrast, the cardiologists do provide critical care as a split shared service. And so this is an example of an appropriate attestation from the critical care attending, saying how much time they spent, and they spent 31 minutes, which was non-overlapping. And then the critical care time for the advanced practitioner in their note was 40 minutes. So it's a total of 71 minutes. And the bill for this critical care hour goes out in the name of the advanced practitioner because they provided the substantive portion, more than half of the total non-overlapping time. Here's an example of a cardiology critical care attestation, 70 minutes with no overlap. And the problem is they copied it from another day. So remember, if you're working in collaboration with an advanced practitioner, your time on the calendar day needs to be the same calendar day as their time, or you're working on 2 different days and you can't pool your time. Many of the Medicare contractors have FAQs. Our contractor in our region of the country, and actually Novitas has the largest proportion of claims in the Medicare system, although they don't numerically cover the largest amount of geography or number of states. And you can go and pull up your contractor's FAQs, and they'll have a lot of this similar information there. I always like to remind everybody, 5 steps to a great note. Say what the patient is critically ill with and list that critical illness diagnosis. Have relevant history and exam, even though it doesn't count anything for the billing because it's good patient care. And specify what service did you provide. Even if you kept the vent the same or you're titrating the norepinephrine, you need to specifically say what critical care service you provided, and that you either didn't overlap or you had non-overlapping time with anything else that might be billable, including another billable provider like an advanced practitioner or a colleague in your group if you've got a nighttime service and the nighttime attending did something in the middle of the night. And of course, document your time.
Scott?
Yes.
We have 2 hands up, Dr. Rose and Sinner.
Go ahead. Thanks.
Hey there. Thanks so much for this talk. I'm Jason Rose. I'm the chief at University of Maryland. We've actually been having a lot of discussions just last week about the split shared with our APP service. We have different groups in our unit. We have an A, B, C. C is with the APPs. The question I had with your expertise is, if we have groups that just have one attending and then a group that has an attending and an APP, same number of patients, it'll flow towards that unit. It'll probably have more total critical care time because you have 2 critical care providers. Is the overlap statement in general like either a time set that it's not overlapping or just saying it's not overlapping with the APP? Is that sufficient, or does it seem like there'll be issues that, hey, why does that C team have way more time overall because they've got 2 providers?
So that is a good question. I'm assuming the A and B teams have house officers.
Correct.
And so the house officer can spend 3 hours of critical care time and none of it's billable. And so Medicare has been paying for that same critical care time under Part A to the hospital in support of the graduate medical education program. So you got the same number of people providing the same amount of critical care, but the dollars are flowing from different buckets into 2 different wallets, if you will. So that would be the explanation for why there's more critical care time being billed on your C service, because the critical care time billed by the residents and fellows on your A and B services is being paid for by a completely different mechanism.
Thank you. That's extremely helpful.
That was a great question, and I got to tell you, in many years of doing these, that's the first time I've ever been asked that question, and it is a great question.
Thank you.
Cy, there was another hand up.
Yeah. Hey, Scott, Jonathan Steiner again.
Oh, John, hi.
Me again. Yeah, so we have a very large APP service, so we spent a lot of time looking at this. And I was just trying to clarify because it sounded like you had a different workflow in your cardiology service from your MICU.
Yes.
And I didn't quite understand, I didn't quite understand because it sounded like you were saying the attending in your medical ICU was writing the note and then it was going under them. Can they do that even if the APP spent more time?
Well, the APPs are not writing any note and they're not tracking their time, and the attendings are billing for their critical care time. So we've got a couple of different models. The teaching service is similar to the A and B service at Maryland with interns, residents, and fellows. And we've got a couple of ICUs with advanced practitioners. And so the attendings just write the notes and track their critical care time. We've got another ICU at Presbyterian where it's hospitalists, typically folks who've graduated from their internal medicine residency, and then they're looking for something to do. And so instead of being a inpatient hospitalist on a general medical service, they function as a critical care hospitalist under the supervision of an intensivist. And we use the same workflow. They take care of the patients, function like house staff, but the attendings round with them, have lots of overlapping time, write the notes, and just count and bill for their time as the substantive portion of the service.
Okay. So I was asking because our compliance folks did not feel that if the APP was providing service that they could not document that if they were, because they're in our group. I don't know what the rule is, but the reason it comes up is then the attendings on that service often are spending a little less time than the APPs because the APPs don't, they have 4 patients, the attending may have 12, right? So they're not going to, and so then the attending on that service ends up like essentially losing all their RVUs and it's going at a lower rate because it's going under the APP. So that's a internal problem for us, but that's why I was interested in what you were doing.
And it's a general problem internally in general with advanced practitioners because everybody's looking to not lose the physician revenue, but we want to start billing for all those billable advanced practitioners, but it is cannibalism.
Right. Okay. So you have the same issue. We're just trying to figure out to thread the needle because now that for those Medicare, you have to get up to 104 minutes. It can be pretty difficult to get the talk. Like in theory, the 2 people would add up and you get past the 104 minutes, but that's a lot of time on your average critical care patient per day.
Yeah. And if you just do the math, 104 minutes for 12 patients.
Right.
Not enough hours in the day, right?
Exactly. So, all right. Thank you.
Sure.
Oh, Scott, 2-minute warning. And I wanted to mention that just a plug for Dr. Hatcham is that he has a survey regarding this that he'll be sharing at the in-person meeting, we hope, if that works for him. But that would sort of do a survey has done a survey and has results across the nation about APPs and their role in pulmonary critical care divisions. And but Scott, I wanted to give the last 2 minutes to you, but I wanted to make the plug for Dr. Hatcham.
Great. Thank you. Thank you for the 2-minute warning, Si. We've had such great questions. I'm just going to give an overview of the additional slides that are in the talk here where I review the split shared regs in the context of hospital visits as well as critical care time. There's some examples of attestations. This is a common problem. The advanced practitioner admitted the patient on the 24th, and the attending wrote their attestation on the 25th, emphasizing what I said earlier, it has to be on the same day. And a reminder, all the split shared services need to have the FS modifier. This only applies to critical care time, not procedures. And so when the advanced practitioners perform procedures, Those have to be billed under the name of the advanced practitioner. If they are supervising someone else doing the procedure, it is unbillable. They can't supervise a student, they can't supervise a resident, because supervision like that is under the teaching physician regulations, and the advanced practitioners are not teaching physicians. This is a bonus slide for all of you. Many faculty get confused. Their head spins, particularly those who are on service as few as 2 or 4 weeks a year. And they say, what the hell am I supposed to do if it's a student? What am I supposed to do if it's a resident or a fellow? What am I supposed to do if it's an advanced practitioner? What happens if I see the patient the same day? What happens if I see the patient the next day? What happens if I don't see the patient at all? So those 9 scenarios are spelled out here. The UPHS attest is one of our smart phrases that prompts the physician what to do in each of those situations. And I encourage everyone to create the equivalent guide for your infrequently practicing faculty so that they know what to do in each of these 9 scenarios in your particular situation. And so thanks again for the opportunity. I'm going to stop sharing slides and look forward to seeing some smiling faces. I know we're at the end of the hour, but I am happy to stay and continue answering questions for anyone who would like to stay on and fire away.
Thank you so very much, Scott. This has been
You're welcome.
exceptionally helpful. You've been wonderful and generous to our group, both in the first presentation and the second. We really greatly appreciate your expertise and your generosity and willing to share it.
Happy to.
Any questions? Last minute, Sai, anything else you would like to add to the group?
No, I wanted to thank Scott. I want to be mindful of time and everybody's busy schedule, and especially when you say that it's a speech, we want to keep it short.
All right, and remember, I'm easily available and open to anyone. You can call me, text me, email me, and I do have a thumb drive. We'll travel.
And Sai, we also clarified that we could share the slides, Sai?
Yes, I sent a PDF to Lauren, so she can send that around in addition with the hot link to the recording.
Excellent.
Thanks.
Wonderful. Thanks, Scott. And for others, please pass it on to your colleagues because I think the more people, we are making it mandatory viewing here. But greatly appreciate your time and efforts, Scott.
You're welcome.
And thanks.
All right. Stay well. Bye-bye.
Thank you so very much.
Bye-bye.
Yeah, bye-bye.